It's lovely and amazing talk with a lot of knowledge. So my name is Umer. I'm a consultant orthopedic surgeon and also now the president of Pakistan Hip and Knee Society. So let's see if it works. So if you look at the knee joint, every part of the knee joint is different. The medial meniscus is different from lateral. The MCL is different from LCL. The ACL is different from PCL, not only in the shape, but structure and also function. But the most amazing part, they all work together in harmony to provide kinematics required for the knee to function normally. Now, obviously, we know the function of the meniscus is stability, lubrication, congruency, proprioception, and load bearing. And it's actually the load bearing mechanism that provides that stability. And if that is lost and round ball is on the flat surface, the risk of arthritis increases. And we have now enough evidence to support that. We know that if somebody has a meniscal surgery or the meniscus is lost, the risk of arthritis is quite high. Looking at the biomechanical study, especially if you look at this study, it clearly demonstrated even so long ago that if somebody has a posterior root tear, they lost the hoop stresses, meniscus extrusion, and also increase in contact pressure. And from time zero, if you look at this X-rays, the patient in a young age losing their meniscus can lead to further wear and tear and also arthritis leading to partial knee replacement or osteotomy. We know that there are many complications of meniscectomy. On the lateral side, it is obviously slightly less with chondral damage, pain, and swelling. And we also know that the result of meniscectomy, if especially in a stable knee, if you do a partial meniscectomy or minimum meniscectomy, the results are still satisfactory. But if you look at this slide by Peter Verdonk and René Verdonk, they showed the importance of meniscus at 25 years. Said if somebody has a normal meniscus and an ACL reconstruction, the risk of arthritis is much less comparing to someone who has subtotal meniscectomy and completely torn meniscus. The results is almost 100% risk of arthritis at 26.5 years. Another study by Calais, an old study, but a good results, 10 years follow-up. If you look at in the beginning, you can see somebody with an ACL lesion, the risk of arthritis along with meniscal lesion and cartilage lesion. If you have this category with somebody who has got a torn ACL, meniscal lesion and meniscectomy and cartilage lesion, 10 years down the line, you have a risk of 40% development of osteoarthritis. But what is meniscal extrusion? In the last few years, the interest toward meniscal centralization has developed quite a lot. And now we have got much more understanding about its pathology. It is actually displacement of the main body of meniscus 3 millimeters outside the joint, potentially saying that it is exactly the same like malalignment, in which you have a varus malalignment and valgus malalignment. With meniscus, the meniscus is outside, it's not aligned, and that's the reason the stress forces on the medial or lateral compartment is huge, leading to arthritic changes. If I show you this video, in this case, as you can see, there is a huge gap between the tibia and also the meniscus, which is the meniscotibial ligament. And in cases like that, the option we have is to consider doing meniscal centralization. What are the main causes of meniscus extrusion? The main cause can be a ramp tear, which my colleagues mentioned, and Professor LaPrade beautifully described the root tear, and also degenerative meniscal changes. Let's look at the study. This study showed very clearly that if somebody has got a medial meniscal root tear, they have a very strong evidence to support that they will also have high risk of meniscal extrusion. But what is meniscal attachment? Now, if you look at this picture, you will see that the meniscus attachment onto the articular surface is called meniscotibial ligament. And the study which was published in 2019 demonstrated that isolated injury to the meniscotibial ligament actually during the pivot shift, secondary to the counter-coup mechanism of the semimembranosus, which is attached onto the capsule, can lead to isolated injury here. And these patients on MRI scan does have evidence of meniscus extrusion leading to arthritis. What is meniscal centralization? Meniscal centralization is to bring meniscus back into normal mechanical position, which is where it should be. What are the results? Meniscal centralization reduces excursion, improve biomechanics, and the study in which they looked at it showed that the meniscal centralization technique actually improved biomechanics, radiological outcome, and clinical outcome. Another study of meniscal centralization with its effect on meniscal extrusion and biomechanics, a very good study, a systematic review published showed the same result. This study, which was published in 2024, showed that the clinical effect of meniscal posterior root repair with combined actually technique showed better outcome pairing to only meniscal root repair. And they showed that even though both procedures were beneficial, but combination of meniscal root with centralization showed better outcome. So what are the technique? Obviously, operative technique is a day case procedure. You do a standard arthroscopy. You need to have all the gadgets you require for meniscal preparation. Suture anchors. There are multiple ways of doing it. I will show you a basic way in which you can proceed with the meniscal centralization. Initially, you start up with the diagnostic arthroscopy, like I showed you in the technique. You examine the knee. If you have an ACL reconstruction, you complete that. If you have any other procedure, you finish that off. And then you look at the meniscus. I always prefer doing the MCL release. This is a video for meniscal scaffold, just for your knowledge, to open up the knee joint so that you can accommodate the anchors easily. And this is a very short video showing that after the meniscal centralization, the same gap which was opened here is closed. So the first part is obviously looking at the root. You always repair the root. You take the sutures, you prepare the bed, you do the tunneling. I won't go into detail because Prof. LaPrade has covered that. And you put your sutures and prepare that, but you should not fix it until you have done the centralization procedure. This is an important slide to mention because during the meniscal centralization, if I stop this here, during the meniscal centralization, it's very important to have high anteromedial port, because imagine yourself that you need to put anchors here. If you don't have access point, it's very difficult to put all suture anchor. Once you have multiple ports available, then you can start release of the MCL using RASP, like it's done here, to open up the space for accommodation of that anchor. I use all suture knotless anchor onto the tibial articular surface. You can use 2 or 3. And then the suturing technique is surgeon preference. How they want to do with all suture anchor is exactly the same like you do a rotator cuff repair. And you bring the whole suture back down onto the articular surface. Once it's done, you fix the root onto the tibia with whatever choice you have, either with an anchor or with the button. And then finally tighten up the central one like it's shown here. Rehabilitation, 0 to 2 weeks protective phase in which you do non-weight bear with crutches. Brace, 0 to 90 passive range of motion with quads, SLR, and ankle pumping. In week 2 to 6, you do control mobilization with partial weight bear, progress to full by 4 weeks. Range of motion to be increased to 120 degree, stationary bike, isometric, and start some hip and core exercise. And by 6 to 12 weeks, the patient starts strengthening program with full weight bear, full range of motion, and closed chain training. So in conclusion, save the meniscus.